a small recap of what we have learned previously. So, the condition of the wall of your stomach, more specifically, the condition of gastric mucosa, is determined by two factors. Number one, damaging factors, and number two, protective factors. Damaging factors are those factors that are continuously trying to damage the wall of the stomach. Protective factors are those factors that are continuously trying to protect it from being damaged. Now, normally, the protective factors, they easily overcome or overwhelm the damaging factors. That's why the gastric mucosa is all right, it's fine, it's not injured. However, in case of an injury, now this injury can be due to one out of two reasons. Either due to an increase in damaging factor, all right, or due to impairment of protective factor. So either due to increase in damaging factor or due to impairment in protective factors, what happens? The damaging factors win over the protective factors. The damaging factors, they overwhelm or overcome the protective factors. When damaging factors win, damage is going to occur. So there is going to be mucosal damage. What is there going to be? There's going to be mucosal damage. If this mucosal damage is not accompanied by inflammation, we call it gastropathy. If this mucosal damage is accompanied by inflammation, we call it gastritis. Now, certain gastritis can worsen over a period of time and result in formation of ulcer. Ulcer is much deeper. That is, it is going to go through mucosa and then involve submucosa and sometimes may even perforate the wall of the stomach. How does ulcer formation take place? This ulcer formation takes place. See, within the stomach, there is hydrochloric acid. Protecting the wall of the stomach from hydrochloric acid are the protective factors. These protective factors majorly include three things: mucus, thick layer of mucus, bicarbonate, and blood, mucosal blood flow. So either due to an increase in HCl or due to decrease in mucus, bicarbonate, blood, the damage to the wall of the stomach takes place, or the burning of the wall of the stomach by HCl takes place, leading to first gastritis and then eventually ulcer. And when you do have ulcer, this is called peptic ulcer disease. But remember, not all gastritis result in ulcer. Only those gastritis where the HCl burns the wall of the stomach, that leads to ulcer. Only those gastritis that burn the wall of the stomach lead to ulcer, peptic ulcer disease. Again, one last time. Gastritis can lead to peptic ulcer disease, but not all gastritis lead to peptic ulcer disease. Only those gastritis that result in damage to the wall of the stomach by the touching of the HCl leads to peptic ulcer disease eventually when it worsens too much. Okay. Now, the topic for this lecture is gastritis. What is gastritis? It is the inflammation of gastric mucosa. How many types of inflammation do we have? We have two types of inflammation: acute inflammation and chronic inflammation. What is acute inflammation? Short-term inflammation that is accompanied with neutrophilic infiltration. What is chronic inflammation? Long-term or recurrent inflammation that is accompanied with lymphocytic infiltration. So if inflammation is of two types, gastritis is also of two types. You have acute gastritis, where you are going to see what throughout the gastric mucosa? You are going to see neutrophils throughout the gastric mucosa. And you have chronic gastritis, where you're going to see what throughout the gastric mucosa? You are going to see lymphocytes throughout the gastric mucosa. First, acute gastritis. So we have talked about lots of damaging factors already under the topic of damaging factor versus protective factor. Was that out before getting into this video? Because if you don't understand that topic, you are not going to understand the pathogenesis of gastritis and peptic ulcer disease. So you need to know the concept of damaging factor versus protective factor. I already have a lecture on it. You can either watch that lecture or read it from your book, whatever be your choice. But for now, Acute gastritis can be caused by any of the damaging factors that I have mentioned, the list of damaging factors, right? At the end of the day, injury to gastric mucosa must take place. If this injury to gastric mucosa results in mucosal damage with inflammation, well, there you go, acute gastritis, where you can see what? Neutrophils in gastric mucosa. Now, out of all these damaging factors, the most common damaging factor is NSAID, or non-steroidal anti-inflammatory drug. What's the mechanism? So non-steroidal anti-inflammatory drug, it inhibits a cyclooxygenase pathway responsible for the formation of prostaglandin. So if there is inhibition of cyclooxygenase pathway, there is also inhibition of formation of prostaglandin. Prostaglandin E2 is responsible for inhibiting the production of HCl to regulate its synthesis and production. Since there is inhibition of prostaglandin E2, that is prostaglandin E2 is not being made, that means there is no one to stop the production of HCl. There's going to be lots of HCl in the stomach. Lots of HCl means what? It is going to go and damage the wall, the mucosa of the stomach, damage it, leading to acute gastritis. Okay. Next, chronic gastritis. Chronic gastritis, I'm going to refer to it as metaplastic atrophic gastritis. And here's why. Gastritis, because there is inflammation of gastric mucosa. There is gastric inflammation, so gastritis. Atrophic, because there is destruction of the wall of the stomach. More specifically, destruction of parietal cells, so loss of parietal cell. So throughout the wall of the stomach or epithelial lining of the stomach, there are bunch of secretory cells. Out of them, one of the most important secretory cells are the parietal cell. The parietal cell. These cells, they are responsible for production of hydrochloric acid and intrinsic factor. There is destruction of these parietal cells, resulting in loss of these parietal cell, resulting in gastric atrophy. So atrophic. Metaplastic, because following gastric atrophy, there is intestinal metaplasia. That's why metaplastic atrophic gastritis. Again, gastritis because there is inflammation of gastric mucosa. Atrophic because there is gastric atrophy due to destruction of parietal cell or loss of parietal cell. Metaplastic because gastric atrophy is followed by intestinal metaplasia. So metaplastic atrophic gastritis. Remember, metaplastic atrophic gastritis. Now, depending on the cause behind the destruction of parietal cell leading to gastric inflammation and followed by intestinal metaplasia. Again, depending on the etiology or the cause behind the destruction of parietal cells leading to gastric inflammation and followed by intestinal metaplasia, we have two types of chronic gastritis. Type A chronic gastritis and type B chronic gastritis. Remember, A for A or autoimmune, B for nothing, just Helicobacter pylori. So A for A or autoimmune. In autoimmune chronic gastritis, the destruction of parietal cells or the loss of parietal cells take place due to autoimmune disorder. That is autoantibodies. That is your own body starts to make antibodies against parietal cells in your stomach. In type B gastritis, it is Helicobacter pylori infection that leads to destruction of parietal cells. Right? Another thing that you need to remember, A is to B and B is to A. What is this mantra? See, type A is to B and type B is to A. That means in type A chronic gastritis, it is the body of the stomach that is mostly affected. In type B chronic gastritis, it is the antrum of the stomach that is mostly affected initially. Later, the complete stomach is affected. Again, what? A for B, B for A. In type A chronic gastritis, body of the stomach is affected. In type B chronic gastritis, antrum of the stomach is affected initially and later on the complete stomach is affected. But at the end of the day, The concept is, be it type A chronic gastritis or type B chronic gastritis, be it autoimmune chronic gastritis or Helicobacter pylori chronic gastritis, what is taking place? Number one, gastritis is taking place due to gastric inflammation or inflammation of gastric mucosa. Number two, atrophy is taking place due to destruction of parietal cells, and metaplasia is taking place due to intestinal metaplasia. So, they are referred as metaplastic atrophic gastritis. But before you get further confused, I want to make one thing clear. This is something that has been written in Robbins, all right? So in Robbins, if you go through the pathogenesis of type A and type B chronic gastritis, this is what is written. In case of type A chronic gastritis or autoimmune chronic gastritis, it has been referred to as autoimmune metaplastic atrophic gastritis. All right, good. You have autoimmune chronic gastritis, which is also referred to as autoimmune metaplastic atrophic gastritis. I have already explained why. However, in case of type B chronic gastritis, that is Helicobacter pylori chronic gastritis, it has not been referred to as metaplastic atrophic gastritis, but the end result is the same. At the end of the day, it also results in atrophic gastritis with intestinal metaplasia. It's just that this particular term, autoimmune metaplastic atrophic gastritis, has not been written in a separate line, but both of them result in the same thing. That is, both of them result in gastritis due to inflammation of gastric mucosa, atrophy due to destruction of parietal cell, and metaplasia due to intestinal metaplasia. All right, so this was everything in short, but you need to know the mechanism of individual chronic gastritis in detail. So let's look at them. First, type A chronic gastritis or autoimmune chronic gastritis. Here, I have already said that the reason behind gastritis or the reason behind atrophy, that is destruction of parietal cells, is antibodies against these parietal cells prepared by our own body. So there are antibodies against parietal cells prepared by our own body that lead to autoimmune, because there's antibodies against our own cells, gastritis, because there is inflammation of gastric mucosa, atrophic due to destruction of parietal cell, metaplastic due to intestinal metaplasia following destruction of parietal cell. The parietal cell present in your stomach is present to produce hydrochloric acid or intrinsic factor. So if you have antibodies destroying these parietal cell, there's no longer hydrochloric acid and intrinsic factor in your stomach, which results in achlorhydria, absence of hydrochloric acid. Hydrochloric acid is absent. So this is what is going to happen. In your stomach, now there is either no or reduced HCl. Okay, this triggers your body to produce more HCl. There is decrease in HCl. Your body requires HCl for digestion, so body tries to increase the production of HCl. Now, who is responsible for producing HCl? Which hormone is responsible for producing more HCl? It is gastrin hormone. Gastrin hormone. So the body starts producing more gastrin to trigger more production of HCl. Now, which cells are responsible for the production of gastrin hormone? It's the G cells. So the body increases the number of G cells. So there is hyperplasia of G cells. Arey bhai, inside your stomach, the HCl level has gone down because the parietal cells have been destroyed by the antibodies made by your own body. Okay, achlorhydria, there is no HCl or there is decreased HCl, whatever be the case. You require HCl or not? Your stomach requires it, you require it, HCl to digest protein and stuff, you require it or not? So your body now, in presence of decreased HCl, tries to increase HCl. How? By increasing the hormone responsible for production of HCl, and that hormone is gastrin. So the body tries to increase the level of gastrin. How will it do it? It will do it by increasing the number of cells that are responsible for production of gastrin. Cell ही बढ़ा दिया तो gastrin भी बढ़ जाएगा भाई. So increase the number of gastrin, then increase gastrin. So there is achlorhydria, that is no HCl. So the body tries to compensate for it by increasing the number of G cells, hyperplasia of G cells, that eventually lead to increase in level of gastrin in blood serum called hypergastrinemia. So if you test the blood of this particular patient, you are going to find elevated gastrin level. There is hypergastrinemia. Second, decrease in intrinsic factor. Intrinsic factor is responsible for absorption of vitamin B12. So if there is decrease in intrinsic factor, that means there is going to be less absorption or no absorption of vitamin B12, leading to vitamin B12 deficiency in the body. Vitamin B12 is required for the maturation of red blood cell. Folic acid and vitamin B12 is required. So if there is no vitamin B12, maturation of RBC won't take place, leading to anemia. And the type of anemia is a megaloblastic anemia because there is deficiency of vitamin B12. Since there is deficiency of vitamin B12 due to an autoimmune reason, antibodies against the parietal cell, this special type of megaloblastic anemia is called pernicious anemia. Third, since parietal cells are being destroyed, there is continuous stress on the wall of the stomach, stress on mucosa, there is mucosal damage, leading to gastric atrophy because there is loss of parietal cell. So gastric atrophy, and gastric atrophy is followed by intestinal metaplasia. That's why given the name of autoimmune due to antibodies prepared by our own body, metaplastic because there is intestinal metaplasia, atrophic because there is gastric atrophy, gastritis because there is mucosal damage along with inflammatory cells. All right, now I'm going to show you all the histopath that you need to know. First from Robbins and then from Hirschman. First from Robbins. So what's the name of the gastritis? It is autoimmune. Autoimmune, so you won't have to ratamar anything, just follow me. Autoimmune metaplastic, autoimmune metaplastic atrophic chronic gastritis. Is this the name or not? It's autoimmune metaplastic atrophic chronic gastritis. Now let's break it down. Chronic gastritis, that means throughout gastric mucosa you can see lymphocytes, so search for lymphocytes. Second, atrophic, so there is going to be gastric atrophy, so you can search for gastric atrophy as well. Third, metaplastic, there is intestinal metaplasia, that means you can search for intestinal you need to search for intestinal metaplasia as well. So search for lymphocytes in gastric mucosa, gastric atrophy and intestinal metaplasia. Let's look at both the histopath. Throughout the gastric mucosa, all these blue dots that you see, they are lymphocytes. They are there due to chronic gastritis. All these bunch of destroyed glands that you see are the atrophic glands. Third, you can see goblet cells right here. Goblet cells are present where? In intestine. But now they are present where? In stomach. That means there is intestinal metaplasia. Whatever was supposed to be in intestine is now in stomach. There is intestinal metaplasia. Here's a small concept for you. The wall of the stomach is also lined by mucus. The wall of the intestine is also lined by mucus. Good. But the mucus secreting cells in the stomach are different than the mucus secreting cells present in the intestine. The mucus secreting cell in the stomach are the surface mucus cell and the neck mucus cell, where the surface mucus cell are referred to as foveolar cells. The mucus secreting cells in intestine are goblet cells. Here, right now, since the epithelium of the stomach shows intestinal metaplasia, that is why along with foveolar cells, the gastric surface mucus cells, along with foveolar cell, you can also see goblet cells. So there are goblet cells in between the foveolar cells. Another concept that you need to know. I hope you remember Barrett esophagus. I have a complete video made on it, crystal clear, everything that you need to know from viva, MCQ and university exam point of view. In Barrett esophagus, I said that the patient first has chronic gastroesophageal reflux disease. Due to chronic gastroesophageal reflux disease, there is continuous stress by HCl on the lower part of the esophagus, leading to intestinal metaplasia and formation of Barrett esophagus, right? Barrett esophagus. So normally the wall of the esophagus is lined by non-keratinized stratified squamous epithelium, but after intestinal metaplasia, it is lined by simple columnar epithelium along with goblet cell. So the characteristic finding or the diagnostic finding of Barrett esophagus, or the diagnostic feature of Barrett esophagus, is goblet cell. And the way to diagnose it is to use a special stain called Alcian blue stain. The Alcian blue stain stains the Barrett esophagus blue. But why? Here's why. The goblet cells, they produce mucus, and the mucus that they produce is acidic. And Alcian blue stain, it stains the acidic mucus blue in color. That is why the Barrett's esophagus is Alcian blue stain positive. Similarly, the wall of the stomach as well. Initially, normally, it does not contain goblet cell. It contains foveolar cells. Foveolar cell produces mucus. Foveolar cell produces mucus, but this mucus is neutral, so it does not take Alcian blue stain. But after intestinal metaplasia in the stomach, I repeat, just like esophagus, after intestinal metaplasia, there were goblet cells. Similarly, in stomach as well, after intestinal metaplasia, now they are goblet cells. These goblet cells, they contain acidic mucus and they get stained by Alcian blue stain, and they appear Alcian blue stain positive. That's it. So in single line, if I have to say, the wall of the stomach, the Alcian blue stain is negative in case of normal epithelium of stomach, but after intestinal metaplasia, due to the presence of goblet cells, the epithelium of the stomach becomes Alcian blue stain positive. Fine. Now, hormone. This is the mucosa of normal stomach. It contains the mucosal folding, the epithelium, the epithelial mucosa, then it contains the epithelial mucosa, the lamina propria, and the muscularis mucosa with inner circular and outer longitudinal. This is basic knowledge. Now let's break down the word. What do we have? We have autoimmune metaplastic atrophic chronic gastritis. Since there is chronic gastritis throughout mucosa, you are gonna see lymphocytes. There are so many lymphocytes that they end up forming aggregates and forming lymphoid nodules with germinal center. Then atrophic, there is atrophy of the mucosa. Then metaplastic, there is intestinal metaplasia. So now along with foveolar cells, there are also goblet cells. This is what you are going to draw in exam. First, draw the atrophy that has taken place. This is the atrophy. Then throughout the mucosa, there are lots of what? Lymphocytes, because it is chronic inflammation. There are so many lymphocytes that they end up forming aggregates. They end up forming lymphoid nodules. As for lining, so there are your foveolar cells, and then in between goblet cells. Again, foveolar cells with goblet cells. Foveolar cell and goblet cells together. There is obviously the muscularis mucosa with inner circular and outer longitudinal. All right. With blood vessel here and lymphatics there. Good. One last time. All right. So there is chronic gastritis. So there are lymphocytes throughout the mucosa. So many lymphocytes that they end up forming lymphoid nodules, lymphoid follicles with germinal center. Atrophic gastritis. So there is atrophy that has taken place. There is loss of mucosal foldings. Metaplastic gastritis. So there is intestinal metaplasia or presence of goblet cells. Done. Next, type B chronic gastritis or Helicobacter pylori gastritis. So this is what takes place. The gastritis is divided into two phases. So there is an early stage, and there's a late stage. Fine, early stage and a late stage. In early stage, there is increase in hydrochloric acid. In late stage, there is decrease in hydrochloric acid. In early stage, the part of the stomach that is mostly affected is antrum. Remember the formula, A for B and B for A. In type A, it's the body that is affected, and in type B, it's the antrum that is affected initially, and then later on the whole body, the whole stomach. So initially, in early stage, it's the antrum that is affected, and then later on, it's the complete stomach that gets affected. Now, what we need to know, how is it that in early stage there is increase in HCl, and then in late stage it's exactly opposite, there's decrease in HCl? How come? So this is how. In early stage, again, it's the antrum of the stomach that is mostly affected. So antrum predominant gastritis. Here, H. pylori infection causes inflammation. Inflammation is followed by an increase in gastrin. Gastrin is responsible for the production of HCl. So there is increase in HCl production. I said earlier, under peptic ulcer disease, that peptic ulcer disease takes place from such gastritis where there is either an increase in HCl or decrease in protection from HCl. At the end of the day, burning of the wall by HCl. Is there increase in HCl? There is increase in HCl. That means this results in increased risk of peptic ulcer disease. There is increased risk of peptic ulcer disease. Here in autoimmune gastritis, there is achlorhydria. There is no or a decreased HCl. That means it will not lead to peptic ulcer disease. Autoimmune gastritis has no risk of peptic ulcer disease because HCl is less. It is not going to burn the wall of the stomach. Ulcer formation will not take place. Okay. Then this is the early stage. Now for late stage. In late stage, the complete stomach is affected. So there is pan-gastritis. Pan means complete. So complete stomach inflammation. Here, there is loss of parietal cell. That means atrophy. There is loss or destruction of parietal cell by Helicobacter pylori. So there is atrophy. Since there is loss of parietal cell, there is decrease in HCl, decrease in hydrochloric acid. So the same as autoimmune gastritis, in Helicobacter pylori gastritis as well, there is no risk of peptic ulcer disease. There is no risk of peptic ulcer disease. Plus, it is protective against esophageal adenocarcinoma as well. How? Again, I have mentioned about this under the topic of esophageal cancers. So watch that out as well if you can. With that being said, in short, here's the esophagus and here's your stomach. Here's the HCl. The person has chronic gastroesophageal reflux disease. As a result, there is stress from HCl continuously, resulting in intestinal metaplasia and formation of Barrett's esophagus. Barrett's esophagus increases the risk of adenocarcinoma. Esophageal adenocarcinoma. But at the end of the day, what is the factor behind it? If you trace it back, it's HCl. HCl is the one that is responsible for causing intestinal metaplasia and then Barrett's esophagus and then adenocarcinoma of esophagus. So if there is decrease in HCl, even if the lower esophageal sphincter is open, decrease in HCl, intestinal metaplasia won't take place, Barrett's esophagus won't form, and adenocarcinoma of esophagus won't take place. That is how this decrease in HCl is a protective against esophageal carcinoma, or Helicobacter pylori gastritis in its late stage is protective against esophageal adenocarcinoma. Since number one, there is destruction of parietal cells, it's atrophic. Since there is inflammation of gastric mucosa, it's gastritis. Since the atrophy is followed by intestinal metaplasia, it's metaplastic. And this intestinal metaplasia increases the risk of adenocarcinoma. Again, let's stress back to esophagus. Under esophagus, I just told you the story of chronic gastroesophageal reflux disease, where the HCl in the stomach continuously burns the lower part of the esophagus, resulting in intestinal metaplasia, which forms Barrett's esophagus and then adenocarcinoma of esophagus, right? So there is intestinal metaplasia, eventually leading to esophageal adenocarcinoma. So intestinal metaplasia is increasing the risk of esophageal adenocarcinoma in esophagus. Similarly, the intestinal metaplasia in stomach also increases the risk of adenocarcinoma. I can't make it more relatable than this. I can't relate the two topics more than this. So, well, this is it, whatever. Now, pictures. So I have from Robbins, this is from internet, and then this is from Horsemohan. First, Warthin starry silver stain. Now, if you know your microbiology, you must know that silver stain is particularly used as an impregnation stain. What is impregnation stain? So it is used for thin structures like flagella and thin bacteria like spirally coiled bacteria. What silver stain does is that it wraps around the bacteria or that thin structure and then fattens it up. This fat structure is now visible under the microscope as black structures. So there's your thin spiral bacteria. The silver stain, it wraps around this bacteria, impregnates the bacteria and then fattens it up. This fat strand is now visible black in color under microscope. So all these fat strand, black strand that you see, these are all Helicobacter pylori that has been stained black due to Warthin starry silver stain. Next is Giemsa stain. Then it is chronic gastritis. So you are going to see lots of lymphocytes throughout the mucosa. Again, so Giemsa stain, H&E stain, diagram to draw in exam. So there's your gastric mucosa with mucosal folding, lined by simple columnar epithelium with thick layer of mucus protecting it from outside. However, now you need to remember 2 points. You have chronic gastritis, right? Chronic gastritis due to Helicobacter pylori. So Helicobacter pylori chronic gastritis. Since there is chronic gastritis, what are you going to see? You are going to see lymphocytes. So these are all the lymphocytes. The complete mucosa contains lots and lots of lymphocytes. There are so much lymphocytes that they end up forming lymphocyte follicles with germinal center. Helicobacter pylori infection. So you're going to see Helicobacter pylori as well. You saw in these histopath as well, there were Helicobacter pylori that you saw with Warthin starry silver stain, Helicobacter pylori with Warthin starry silver stain, Helicobacter pylori with Giemsa stain, Helicobacter pylori with Giemsa stain, Helicobacter pylori with H&E stain. Similarly, lymphocytes, lots of lymphocytes. As for drawing in exam, this is what you are going to draw in exam. So there's the mucosal folding lined by the gastric epithelium, right? And then outside are Helicobacter pylori. So these are Helicobacter pylori. Since it is chronic inflammation, there's going to be lots and lots of lymphocytes throughout the mucosa. There are so many lymphocytes that they end up forming lymphoid follicles with germinal center. Obviously, since it is lamina propria, you're going to draw blood vessel, and then you're going to draw some lymphatics, and then you're going to draw the inner circular muscle and then outer longitudinal muscle. This is the diagram for you to draw in exam. With that, we are done with the gastritis. One last revision. This was a little complicated topic, but I hope you understand now. So this is the final revision. Gastritis, it is the inflammation of gastric mucosa. It is of two types: acute gastritis, which is mostly due to non-steroidal anti-inflammatory drug, and chronic gastritis, which is also referred to as metaplastic atrophic gastritis. Gastritis because there is inflammation of gastric mucosa, atrophic because there is gastric atrophy due to destruction of parietal cells, and metaplastic cause gastric atrophy is followed by intestinal metaplasia. Depending on the cause behind atrophy and gastritis eventually leading to metaplasia, we have two types of chronic gastritis. Type A, which is autoimmune chronic gastritis, where antibodies against parietal cell made by our own body are responsible for metaplastic atrophic gastritis, and type B, where Helicobacter pylori infection is responsible for destruction of parietal cell leading to gastric inflammation followed by intestinal metaplasia, or what we call as metaplastic atrophic gastritis. First, type A chronic gastritis or autoimmune gastritis. Here you have antibodies against the parietal cell, so there is destruction of parietal cell leading to atrophic gastritis, which is followed by metaplasia, intestinal metaplasia. So metaplastic atrophic gastritis, since it is chronic, it is metaplastic atrophic chronic gastritis. Since it is due to antibodies made by our own body, it is autoimmune metaplastic atrophic chronic gastritis. Here three things take place. Since parietal cells are destroyed, there is decrease or no HCl, so achlorhydria leading to hypergastrinemia. Since parietal cells are destroyed, there is no intrinsic factor leading to pernicious anemia. Since parietal cells are destroyed, there is damage to gastric mucosa, injury to gastric mucosa, gastric atrophy followed by intestinal metaplasia. Under histopath, you can see all of those features. You can see lymphocytes due to chronic inflammation, chronic gastritis, atrophic glands due to atrophic gastritis, and intestinal metaplasia due to metaplastic gastritis. Intestinal metaplasia is characterized by the presence of goblet cells, which gives allicin blue stain positive. In Hirschman as well, the diagram for you to draw in exam has been given. There is atrophy taking place, lymphocytic aggregation that has taken place, as well as goblet cells due to intestinal metaplasia. Then you have type B chronic gastritis, which is due to Helicobacter pylori, divided into two stages. There's early stage and late stage. Early stage, you have antrum dominant. Late stage, it is the complete stomach invert, so pan gastritis. Early stage, there is increase in HCl. Late stage, there is decrease in HCl. Early stage, there is increase in HCl due to inflammation followed by increase in gastrin, which results in increase in HCl. When there is too much HCl in the stomach, it can go and burn the wall of the stomach, leading to formation of ulcer and eventually peptic ulcer disease. However, in late stage, since there is destruction of parietal cell, there is decrease in HCl, which does not put any risk in development of peptic ulcer disease. No HCl means how ulcer, how ulcer means how peptic ulcer disease. No risk of peptic ulcer disease. Plus decrease in HCl also acts protective against esophageal adenocarcinoma, which I have already explained, finally leading to Helicobacter pylori metaplastic atrophic chronic gastritis. Again, chronic gastritis because there is lymphocytic infiltration in gastric inflammation, atrophic because there is destruction of parietal cell leading to gastric atrophy, metaplastic because this loss of parietal cell or gastric atrophy is followed by intestinal metaplasia. Since there is intestinal metaplasia, there is also an increased risk of adenocarcinoma. Since everything is happening due to H. pylori, we call it H. pylori or Helicobacter pylori metaplastic atrophic chronic gastritis. This is what you can see in Robbins. So there's your lots and lots of Helicobacter pylori present and stained black by Warthin starry silver stain. Giemsa stain can also be used. These are lymphocytes because there is chronic gastritis. You can see the Giemsa stain and then H&E stain, and this is what you need to draw in exam. You need to show that there are the spiral bacteria or Helicobacter pylori along the wall of the stomach or the epithelium of the stomach, and within the mucosa there are lots of lymphocytes because there is chronic gastritis, and these lymphocytes end up forming lymphoid follicles with germinal center.